Hi everyone. We are privileged today to have Prof. Anand with us. Prof. Anand is a cardiothoracic surgeon at Sunway Medical Center. Prof. Anand, can you briefly introduce yourself to us?
Hi Ankush, thanks for the kind invitation. So I've been a doctor for about 27 years.
Wow.
And I've been practicing as a cardiothoracic surgeon for the past 15 years. And as cardiothoracic surgeons, as you know, we're involved in looking after patients with serious heart conditions, as well as we're involved in diagnosing and treating patients with various diseases and disorders of organs in the chest cavity, most notably the lungs. So over the years, a lot of my interest, passion, and expertise has developed in lung cancer. And that is a large part of my clinical work as well as my academic research. As you know, Ankush, lung cancer is a very common cancer and common cause of cancer death across the globe, including here in Malaysia. And in fact, in Malaysia, we are burdened with a lot of late-stage presentation. The vast majority of cases are being diagnosed too late. So one of the areas of interest for me, both clinically and in terms of research, is to see how we can detect and pick up the disease earlier. What you and I would refer to as stage shift or stage migration, and a particular emphasis on screening, including innovative technologies like artificial intelligence, as well as biomarkers, like ctDNA and so forth. But not all is lost, In recent years, the treatment paradigm for lung cancer has evolved considerably for the better. We're seeing far better patient outcomes. And I think that's a reflection of the tremendous advances in the diagnostic and treatment landscape.
Thank you, Prof, for that introduction. Sure. And yes, Prof, your special interest for lung cancer. And you also mentioned about your interest with AI and ctDNA. So we know these technologies have actually evolved over time and are now more helpful to detect cancer early, because at the end of the day, that's what we want to do, if not prevent, right? So can you tell us more about your experience with ctDNA, or any particular interesting case you would like to highlight?
So ctDNA is an evolving technology and is showing immense potential in the cancer space, particularly for lung cancer. Certainly, for example, patients who are diagnosed with lung cancer and are being treated, and of course surgery would be the treatment of choice for early stage disease, we may measure the tumor marker levels as a baseline pre-treatment, pre-surgery, and then it has the potential to monitor for disease relapse or recurrence, something we term as MRD, minimum residual disease. And we see great potential with ctDNA in this setting in terms of monitoring the patient together with conventional surveillance, CT scans and PET scans. And perhaps it will allow us to personalize scan intervals as well as to escalate or de-escalate adjuvant treatments after curative intent surgery in the early lung cancer space. Equally exciting, perhaps a bit more challenging, is to see how we can position the technology to better screen and diagnose for lung cancer. As we were both saying, the disease burden is high in Malaysia and globally, and a lot of late-stage presentation. So presently, the standard of care is still very much using imaging, a low-dose CT scan, and in countries like Malaysia and other sort of low and middle-income nations, it is a very reasonable strategy to use AI-enabled chest x-rays, chest radiography. They are scalable, it can be deployed remotely, perhaps as a triage, as a funnel to identify individuals who may have an abnormality in the x-ray, who will then go on to have a definitive low-dose CT scan. So to answer your question, I think ctDNA has immense potential even in the screening and diagnostic space, perhaps to help better risk stratify and define those individuals who may have an abnormal finding on their initial X-ray or CT scan. Yeah.
Yes. I agree. I mean, ctDNA is now growing as in different phases of lung cancer, right? Maybe comes into play where there are those lung nodules or IPNs, I think, as you would call them, or maybe also for monitoring of the disease. But
Absolutely.
just again, going back towards the diagnosis of early lung cancer. So we all agree the role of the AI, X-ray, and the LDCT. I mean, of course, LDCT is the gold standard for lung cancer screening at present. But then again, I mean, would you like to share more about your experience with the qualitative ctDNA testing in that setting, or
Sure.
maybe the recent case that you had for some.
Sure. So you're right. So we've had a reasonable early experience. We're using ctDNA, and I can share a very interesting case. A few months ago, one of my colleagues, one of the chest physicians, pulmonologists here in Sunway, kindly referred a patient. So this is a lady that would not be normally captured by traditional screening criteria. She was a Chinese lady in her mid-40s, and she was a non-smoker with no family history of the disease. And she just went for a health screening. And as part of the screening package, she had a chest x-ray and subsequently was found to have a opacity, a shadow in the lung, in her right lung. And quite rightly, she was then further investigated with a CT scan. And as you mentioned, Ankush, we term this as an IPN, an indeterminate pulmonary nodule, which means we don't actually know at this point in the patient journey what it is. And in her case, it was a very small, about 1 to 1.5 centimeters opacity. The radiological term we use is GGO, ground glass opacity. And unfortunately for her, it was right in the middle of her lower lobe. So the right lung has 3 lobes, an upper, middle, and lower lobe. And this was smack in the middle of her lower lobe. So she was referred to me for further evaluation and to see what are the next steps in the investigation or management. And I spent some time, what we do in the clinic is clinical risk profiling. So we look at the patient's age, their ethnicity, their gender, their smoking history, family history for lung cancer, family history in general, as well as we look at the features of the nodule or the opacity on the X-ray or the CT scan. For example, if you had an opacity that had an irregular border, we call this spiculated, and it's perhaps more likely to be cancerous, malignant. Whereas if we had a nodule or an opacity that had a smooth, round border, it is more well circumscribed or well demarcated, or it's calcified, then those are usually signs or features of something that is more benign. So we do this clinical risk profiling as well as evaluating the morphology of the nodule or the opacity on the X-ray or the scan. And then we try to guide the patient on the next step in that journey. Her situation is not unusual. We do have these scenarios quite often. And I then explained to her that the finding on the X-ray and the CT scan could be one of a number of things. Quite likely, this could be benign pathology. It could be a resolving pneumonia or focal pneumonia, a bit of infection or inflammation. It could also be a benign lung nodule, quite common. But of course, one of the things we are concerned about and would be the possibility of an early stage lung cancer.
Oh, so in this case, as I understand, your differential diagnosis can actually vary from a very inflammatory, infectious process to benign nodule to malignancy. So it's really variable for the patient, right?
Absolutely.
And was this patient the right, what would be your next step? Would you do biopsy for such a patient?
Yeah, so that's a great question, Ankush. So a lot of it depends on our clinical suspicion, index of suspicion of the likelihood that this nodule opacity is a cancer or not, as well as patient's anxiety level or level of concern. So in her case, to be very honest, it was quite equivocal. It had features that were neither classic or typical of a lung cancer. At the same time, it didn't look entirely benign. And we explained to her that there were a few options available. The first being that a very reasonable option would be to continue to monitor. We call this watchful waiting. So I would advise her to see me at an interval of 4 to 6 months with a follow-up surveillance scan. And what we're doing there is we're giving time for nature to declare itself. And on the follow-up scan, if that nodule or opacity were to change in size or shape, and that would give us cause for concern, then perhaps we need to intervene. Of course, the drawback with this approach is that, aside from patient anxiety and sometimes the doctor's anxiety, the worry that we could miss something, the drawback with this approach is if it were a lung cancer, during that interval of 3, 4, 5, 6 months, there is the potential for the tumor to grow or even spread. The other option which I discussed with her and we do with patients in this scenario is to go for a biopsy. So these 3 options we would often or always discuss with patients, including this particular lady. She was quite clear that she wasn't keen on the surveillance, continued surveillance,
Okay.
as well as seemed a bit concerned about the percutaneous CT-guided biopsy for the very reasons we discussed, the risk of lung puncture, not getting an answer, non-diagnostic biopsy, and tumor spread. So at this point, Ankush, I think we then thought perhaps we should be a bit more innovative, and this is where we utilize the blood test, the spot mass lung ctDNA blood test. As you know, it's basically taking a sample of peripheral blood, and what we're trying to do is detect cancer cells. So some cancers may shed DNA, shed cells, tumor cells, which may be detectable in the peripheral blood. And so this was a simple blood test. And then we said we would try to refine the decision based on the findings of that.
I think, yes, you're right. I mean, the options for the patient would be many, but I think in the end depends on what the patient wishes to choose as well, right?
Absolutely.
So in this case, so you went with the spot mass lung test. I just want to understand, because it's a new technology, patients may not have heard of the term ctDNA or the use of AI in diagnosis, right? So how did you counsel the patient, and what actually resonated with the patient to undergo this testing that is relatively new, even for the HCPs at this stage?
Sure. So you're right. So it is fairly new technology, and I spent a considerable amount of time explaining to the patient and her husband, that first of all, what I would always say is no one test or investigation is infallible. There's no absolute 100% accuracy in any diagnostic or screening test. When we talk about investigations, we talk about sensitivity and specificity and positive and negative predictive values. And it's just an extra data point that we use together with the clinical risk profiling and the imaging information to guide our decision. So I explained to her that the opacity in her lung may or may not be a lung cancer. And obviously we had discussed the complexities and the pros and cons of a biopsy. And so we felt, let's utilize this new technology, the blood test, the ctDNA, and how we decided we would use it if we got a positive result that would push us in the path of going for surgery or a biopsy. If it were a negative result, perhaps we would be a bit more conservative and continue on the path of close surveillance. So I explained to her that the tests entail just a blood test, taking a sample of peripheral blood. I think it's about 10 mils. There is a bit of a turnaround time, and we will wait for that result. Conceptually, we talk about the cancer shedding. Some cancers shed cells, and it's detectable. And I believe spot mass ctDNA uses quite state-of-the-art AI technology and deep sequencing technology, next generation sequencing. And the idea being able to pick up signals, your genetic and epigenetic molecular signatures from the tumor or the tumor fragments that are in the peripheral, in the bloodstream. And the test itself is qualitative, and you get a report, which is very important for us to explain to patients. It's a binary report. It's either going to be positive or negative. The report, as you know, comes with a score, a Z-score. Now that is quantitative, and I think the cutoff is above 3. But I always explain to the patients that doesn't impact on the clinical decision making. That is more for internal sort of validation and quantification. But really, we're talking binary. Either you detect a ctDNA signal or you don't. So it's a positive and negative test. I do, however, tell them, as with any test, as I mentioned, we can have false positives and false negatives so that we manage the patient's expectations. It is not a substitute for clinical acumen, but certainly it is an extra data point, I think, which helps us as clinicians and the patient to make important decisions, in the next step of that journey.
Yeah, thank you, Prof, for sharing such clarity on the utility of the test, right? Because it's not really clear to a lot of people where exactly to place the test, and also to make it simple for the patient to understand, right? Because at the end of the day, we want informed consent from the patient as well, understanding the advantages, but also understanding the limitations of the test. So coming back to your patient case, so for this patient, the result was, what was the result?
What happened was her result came back as a positive result. I think the Z-score was above 3. And she saw me back in the clinic a few weeks later once we had the result. And we went with what had been discussed. She was very keen to proceed with surgery, to have it removed. And she underwent successful surgery, minimally invasive surgery, and lo and behold, it came back as a lung cancer, as an early stage non-small cell lung cancer. The most common subtype that we see was an invasive adenocarcinoma. So, here was someone, in her mid-40s, a non-smoker with no family history. This was really an incidental finding, picked up on health screening. She was otherwise fit and well. She used to go hiking and running. And because she was diligent to pursue health screening, this was picked up. And I guess here the ctDNA, the blood test, certainly played a pivotal role in guiding both me as the treating doctor and her as the patient to take that next important step. And I think that's made all the difference in this particular case. I mean, to be honest, if the result was negative, I probably would have advised her to continue in the path of close surveillance and follow up at an interval of 4 to 6 months. And if it was still a cancer, hopefully it would still potentially be at a stage that is amenable to curative treatment with surgery.
So for this case, I mean, spot mass lung did play a very crucial role for patient management. Just wondering, because maybe a few years back we didn't have this technology, right? So in case, there was no spot mass lung, then you would still have this patient, and given the current clinical scenario, what you think you would have done for the patient, and do you think spot mass lung made any change in your clinical decision?
So like I was saying, this particular case, it clearly did, with the benefit of hindsight looking back. So in the absence of such technology years ago, we would very much base on our clinical risk profiling, as well as taking into consideration patient sentiment. Some patients are incredibly anxious and worried. I always tell patients any intervention carries risk, including non-intervention. So we'd have to balance the risk of close surveillance, watchful waiting, the conservative approach, which is often very reasonable and the correct way in many patients, versus invasive, either going for a CT-guided or endobronchial or surgical biopsy or upfront surgery. And it's very much a personalized, individualized decision based on, on a case-by-case basis. But so this technology gives us hope that perhaps we can help to better risk stratify those indeterminate nodules. Obviously, for patients who have features that are very typical, characteristic of a lung cancer, we have a much lower threshold to guide them for a biopsy or surgery. Or in cases where they've already had a biopsy ankush and we have a histological confirmation of lung cancer, then we're going to proceed in the normal clinical pathway of staging and then proceeding with the appropriate, stage-dependent treatment.
Yeah, thank you, Prof. I think you've beautifully put this technology may be more useful for those indeterminate nodules, right? So maybe we go into the more scientific concept of it, because we know there's something called the lung RADS scoring, right? When you do the imaging of the patient. So in terms of lung RADS scoring, where exactly would you place this spot mass lung test? Because it's still meant for patients who have undergone some form of imaging, right? That's what I understand from this patient journey. So where exactly, let's say now in your current clinical practice, where exactly would you see the utility of a spot mass lung?
So that's a great question. So, a lot of my clinical and research is focused on, as I mentioned, stage shift, trying to pick up disease earlier. I think we have to, I see technology like ctDNA to complement, augment imaging. And for me at the present time, I think it is a bit challenging to use it in isolation. I would feel more comfortable that for any screening to be cost effective, it has to be targeted. Therefore, we need to target the high risk population, which at the present time, I would advocate those with a tobacco smoking history, current or former smokers of at least 20 years, and those high-risk non-smokers whom we define as individuals with a salient family history of lung cancer, first-degree relatives, siblings, and so forth. So at the moment, I think, ctDNA, or liquid biopsy, these blood tests, can be positioned to help risk stratify a nodule, something that we find on imaging, to augment and complement and guide clinician and patient or the person on the next step. I hope as time goes, it may even be able to then predate the imaging, because clearly there's no radiation involved and perhaps it's even less costly, but that remains to be seen.
And I think, Prof, because you've had some experience with the ctDNA tests, is there any advice you would give to the HCPs who may be, at that step where they want to adopt this technology into their clinical practice? Because at the end of the day, we want to be aware of definitely the advantages, the clinical applications, and at the same time, the limitations of the technology as well, so that it can be applied in the right clinical sense, so that it provides more information to you as a clinician and to the patient as well. So just any advice or anything you would like to share?
I mean, you're absolutely right, Ankush. So, any investigation or any test that we do, even if it's non-invasive, as clinicians, as doctors, you're trained to think, how is that going to impact on patient management? What would I do differently? Otherwise, what we're doing is just adding a further burden, financial cost to the patient, and sometimes anxiety as well. So I think this test will be very useful for cardiothoracic surgeons, certainly for oncologists, chest physicians, pulmonologists. I'm talking specifically, I would say, spot mass lung. I am aware there are different types of ctDNA testing for different cancers, including multicancer, early detection, and so forth. So I think there's still no substitute for clinical risk profiling, imaging, looking at the features on the AI chest X-ray or the low-dose CT scan. But I think, technology is evolving rapidly, and this ability to detect in the peripheral blood tumor cells, circulating tumor DNA, shed fragments by the tumor, is very exciting, very appealing. I think the clinicians should be more innovative to adopt this, but judiciously, to help risk stratify those nodules. And be mindful, of course, we can have false positive and false negative results, as with any investigation, as with any test, and be able to manage that as well as the patients. So, you may have, if your clinical suspicion based on all your evaluation is that this person has a likely lung cancer, and even if the ctDNA result were to be negative, I think it's very important that an experienced doctor, surgeon, oncologist, pulmonologist must be able to explain to the patient and the family why they decide not to sit on this and monitor, but rather let's get a biopsy or let's remove it surgically, because that could make a difference. And conversely, Ankush, it's also important we appreciate false positives. Sometimes you may have inflammatory conditions like tuberculosis or an ongoing concurrent infection in the lung that can give a false positive result. So that can sometimes cloud the clinical picture. So I see it as a very valuable added data point alongside risk profiling and review of the imaging to guide, as clinicians, to guide our decision making and to guide the patient on the next step in the patient journey.
Thank you. Thank you, Prof, for sharing. I think it's a very interesting case, and I think we've highlighted a number of key points. The first thing, the need for lung cancer screening, because like you said, healthy, 40-year female, there's no risk factor, but still had this pulmonary nodule. So the need for lung cancer screening cannot be overemphasized.
Absolutely.
And the early detection of lung cancer. And then, of course, comes the role of standard procedures like AI X-ray and LDCT, but then ctDNA can add value for certain cases in indeterminate nodules.
Absolutely.
Thank you. Thank you, Prof, for sharing.